Shall we go to the last case, fifth case?
Yes, sir.
Who is the...
This is actually going to be taken by Dr. Shalina Nair. She's a student of Dr. Lakshmi from Osmania Medical College.
Okay. What's
Shalina.
your name?
Dr. Shalina?
Shalina. Yes,
Shalina?
yes.
Yeah, right, my dear. See, what is this case?
It's a congenital clasp thumb deformity.
Okay. Why do you say clasp to thumb? What is the meaning of clasp?
Clasp is when you grip with strength.
Not strength, just hug.
It's
Hugging also clasp. So we don't need to have a strength to hug anybody. Okay.
Yes.
So it is only hugging, close, very close, right?
Yes.
Now you said it's a clasped thumb. Why you call it as a clasped thumb?
Because there is flexion of the metacarpophalangeal and metacarpophalangeal joint of the thumb, and there is thumb in the palm deformity.
Yes. The clasped thumb is known otherwise thumb and palm deformity. What is the difficulty for the child? Why they should come for treatment?
They won't be able to grip anything because even the function of the other fingers are limited because of the thumb. This thumb cannot move out of the palm.
Rightly said. Yes. They can't grasp because the fingers, when they flex, the thumb will intervene and then do that. See the X-ray and explain me how is the X-ray?
In X-ray, actually, there is a flexion deformity at the metacarpophalangeal joint and hyperextension at the IP joint.
Why there is hyperextension?
Ideally, there should be flexion at the IP joints, right?
Flexion at the IP joint. Why IP joint flexion? You see this?
Because first extensor polys. Yes, here it is flexion at the IP joint.
No, it is not flexion. See this here. For the same case.
Yes.
There is a flexion of the MP joint, I agree. I won't agree with you the flexion of the IP. It is actually here also you see it's hyperextended.
Hyperextension at the...
Yeah. So that means what?
That means the EPL is...
complete it.
Yes, there is a... EPL is hyperacting and EPB is...
not hyperacting, it is present.
It is present.
Yes. Now tell me, what are the things you examine such a case is given to you?
First, we will examine for EPL and EPB function, flexion at the metacarpophalangeal joint, then extension at the metacarpophalangeal joint, then IP joint. Then we would like to see that abductor is affected most of the cases. So I would like to see the abduction of the thumb, whether the thumb is adducted or in adducted position. Then I would like to see for the web space, first web space, whether there is any contracture of the first web space or not.
Very good. You have rightly said, but only your small problem is you must be able to know whether you can correct the deformity passively.
Yes.
So that's what you must say. So
yes.
When you see such a case, you must see the web space contracture.
Yes.
Number 2 is whether you can correct the deformity.
Yes. Whether it is supple and passively correctable.
If you are able to supple and passively correct it, what will you do?
In that case, we can do, and if the child is less than 1 year, then we can give splintage.
Yeah, don't you think that's important?
Yes. Yes.
So you can splint in the first year or 1.5 years, 2 years. If the mother is intelligent, you can even give it for 2 years. Yes. Otherwise, give it for the first year, and then now so nice good splints are now available. We can do that. So this is the point. Look for thumb web.
Yes.
Quite okay here. Palpate the adductor pollicis. Is it working or not?
Yes.
And mobility of all the three joints. And this is why you also said the absence of APL, flexion of the CMC joint, that is not there. EPB is there because MP joint is flexed. Absence of EPL, but here it is present.
Present.
Okay?
Yes.
So how will you treat this child? You said splintage.
Yes.
Suppose after splintage, after some time you see that the same child comes back with the same deformity. What will you do?
After splintage, we have to do the, if it is failed splintage, we have to go for the surgery. That will be augmentation of the extensors. We can
Augment the extensors. What do you mean by augmentation?
That will be tendon transverse.
Tendon transfer is different from augmentation. Augmentation of the function is one thing you can say, or you must do a tendon transfer. What tendon transfer you do?
Extensor indices proprius.
Telling all the transfers. Sorry, there is a small disruption in my mic. What are the transfers you said?
Extensor indices to the EPL tendon, and then abductor. Then Huber's oponoplasty can be done if the abductor is affected.
Anything else other than Huber? Everybody is so happy about Huber's transfer. It's only indicator for when no other muscle will act well. Any other muscle will act to get you the subduction. What is the regular oponoplasty you do for a median nerve or whatever it is?
Not sure, sir.
Not sure. Anybody else who would like to take up the question?
FDS transfer, sir.
Yeah. FDS transfer, there are 4 FDS. Which FDS will you use?
FDS of ring finger.
Why ring finger? For everything you must have an answer, my dear.
Least
Least,
used.
most, least, most, then
Ring finger is not used in grip function, sir, mostly.
Least used finger.
will you use little finger FDS?
Yes. In
Little
the
finger FDS will be very less, sir.
Sorry?
string.
No,
When we are
please.
using the strings and
Hey, don't give me a telegraphic language, give me a full sentence.
musicians,
use-
when
Huh?
musicians they need for
Huh.
the strings.
Who knows this child is going to be a musician or not? It is not like that. Many of these time, these congenital hands, your little finger FDS may be missing. Okay? And very less strength. So always ideal not to use the powerful middle finger. Use the ring finger for your transfer. Okay?
Yes.
You all follow me?
Yes, sir.
Right. Now, this is what the treatment. Okay?
Yes, sir.
EIP to EPB, FDS ring to EPB, or FDS. Then if the appeal, here this particular child appeal is good. If the appeal is also not there, you can transfer FDS to EPL, inner transfer to EPB, and then fix the IP joint in good position. so that will be maintained. Okay.
Yes, sir.
All right. I think we have come to a conclusion. What, my dear, it's the last case. What?
Yes, sir.
Are you okay?
This
Anybody else want to talk something or want me to tell something, or shall we finish with this? What is the time we have taken?
So it's okay, sir. Time-wise, it is okay.
7:15.
7:15, sir.
Okay.
Anyone has got any questions? Please ask, sir.
Please ask. Yes. There is no question box में कुछ
Sir,
नहीं.
It's there, sir.
Nishant want to ask anything?
Yes, ma'am. Sir,
Yeah,
few
you
books they are
address.
mentioning it as congenital hand difference than anomaly. Why congenital hand difference? Is it like just only the terminology or anything different? Why difference they are calling it?
Yeah, not different. See, we used to call it only as congenital anomaly, but everybody felt that word is not a good word to use. That's why the name congenital hand difference came. You say that vascular anomaly, we always say anomaly, but in the congenital hand, it's only the different from what it should be like, what is normal like. So that's why they changed the name as congenital hand difference, and not to call it as anomaly. Anomaly is a word which creates some problem with the parents.
Yes.
Okay?
Yes.
Shall I close? You permit me? What, my dear?
I think, yeah, that's all. So, and then can you just tell a thing also, no? Because none of these, one common question that we get from the patient side is that they come many times, they have uh, absent hand and etc. And then they would come and ask whether this child will qualify for a transplant. Always that question is there. And because nowadays many people are doing a lot of transplants. So this is one thing that is commonly asked by patients of children who come with these kind of problems.
Not
So-
this type of problem.
Yes, sir.
They come only with phocomelia at
Yes,
the
sir.
arm level or forearm level.
Forearm, usually forearm
Yeah.
level focomelia.
Forearm level, you should see in those patients or whoever comes to you for surgery, they should have a good adduction of the shoulder, and also the good function at the level of the elbow. And you must check the vascular anatomy. Most of these congenital cases, even before you do this case, I did the, what do you call, this toe transfer, no?
Yes, sir.
For the child. I did that Doppler 2-3 times to check, because I don't want to do any injection study. We have to do the vascularity, because many of these congenital hands, there is also a problem with the vascularity of the hand. So in focomelia, when they come to you, you must see that the rest of the movements are good. They have a stiff elbow or a stiff shoulder. There is no point doing anything for them. We just give a prosthesis, they'll be better off. Everything is good at the age, not in a younger age. They should at least cross adolescence. Then only you can do something which will make them good. Okay? I
Yes,
don't
sir.
recommend hand transplant for a children or a kid who has got a focomelia. Best thing is to go for prosthesis. Now lots of bionic prostheses have come. We can use them and make them all right and work with that. Because the focomelia happens on both sides also. Be useful to give a prosthesis rather than putting the age, what medication you are going to give is all going to be killing the child. So adults, we can do that. Yes.
Yeah, and another important thing is that by rule, children less than 18 years should not undergo any transplant, because hand transplant is one case where actually even death can actually happen. You could have a lot of other complications. So,
Not only that.
so
That's on the table.
death of the table, yeah, and infections later. like renal problems. I mean, there's a host of cancers coming. So the thing is that the parents don't have the right to actually give a consent for a procedure for a child, which can actually harm the child later. So the rule is that no children less than 18 years should undergo transplants. And another thing is that again, just because the physical hand is there, it might not be functional, and also that brain might not accept this new thing. So that plasticity also would be lost by the time 18 years has passed. So again, that's again another point probably why transplants would not be done, because
No, the last point I may not agree, because you do it early. See, remember the first transplant done in Kuala
right, for
Lumpur.
children. Yes, it was
Yeah,
for yes,
child,
sir.
with both the children, the siblings, they had taken. Dr. The Tyagarajan did,
Yes, sir.
one child's hand for the whole hand was shifted. It was functioning all right. We don't know now because we lost contact with Dr. Tyagarajan also. We are not able to get any information. That can be done. Like this siblings,
Okay, sir.
not in the like unrelated donors, right?
Yeah, where
Is one which should be correct.
correct. Yeah, I think we have come down. We have come to an end of a very good.
Who is that behind your daughter?
My daughter, sir.
Yeah, right. Good.
So now, Dr. Radhakrishnan is there, because
Yes, Sandeep.
yeah,
Sandeep?
yeah, you,
No, because there was this IPL has started, no? So that's why I have to come and isolate myself. Otherwise, I cannot stay. Because, hello, Sandeep?
we can hear you. We can hear you. We can hear you. We can.
The IPL has started, so that's why I just came in between inside the room because children were just shouting. It was a very nice session, sir. Actually, it was a very nice session, quite informative. I think most of the PGs would have enjoyed. And as you said, these hand cases, most of the time we will keep them in spotters, or in very rarely when we need, you may keep them in short cases. So I think most of the doubts would have been cleared in the 2 hand sessions. And Sandeep, any questions in the chat box? I don't think so.
No
Okay,
questions.
okay.
Actually,
Okay.
just to.
Okay.
Oh, there
So
is.
then we can call it a session, I think, sir. Yeah.
Oh, there is one question by Dr. Latika Reddy.
Yes.
What should be the disabilities we should explain to the parents for clasped deformity children?
What
What should be the disabilities we should explain to the parents with a child with clasped?
class thumb? See, the main point is everybody knows thumb is the important finger in the hand. If you lost the thumb, 90% of the function is lost. So you must explain to them, and it is a correctable mistake. To properly catch them early, splint them, and then subsequently do surgery to correct it. So we must explain to them. It's very good to do a surgery or whatever is splinting. Then subsequently, splinting may be done initially, but at the end of the day, they'll end up with the surgery.